Good morning, Dr. Camp and class. This is our Unit 12 video discussion. We have a 79-year-old man with past medical history of cirrhosis secondary to chronic hepatitis C that is presenting to the ED with complaints of abdominal discomfort for the past 3 days. On physical exam, there are signs of ascites. There is a high temperature of 101, blood pressure of 130/90, pulse of 100, and respiratory rate of 22. So first of all, we're going to be getting informed consent for the procedure of the diagnosis. So I will start off with hello, my name is Natalie Franco, nurse practitioner, and I'm here to help ease your abdominal discomfort. I'm going to perform a paracentesis to drain the fluid and send it to the lab for diagnostic testing. This is a relatively safe procedure that will be done at the bedside with ultrasound guidance. However, there are risks associated with this procedure, which includes persistent leakage of ascites fluid from the needle insertion site, abdominal wall hematoma, bleeding, infection, perforation of surrounding vessels or viscera, and hypotension if large fluid amount is removed. I will take the necessary steps to reduce the risks. You can decide to not move forward with the paracentesis if you'd like. However, if you do not, your condition can deteriorate and lead to a spontaneous bacterial peritonitis, and if untreated can progress to septic shock or multi-system organ failure. Alternative treatments to paracentesis is what is called TIPS, a transjugular intrahepatic portal systemic shunt. This is a procedure that involves inserting a stent to connect to portal veins to unjunct blood vessels that have lower pressure, which relieves the pressure of blood flowing through the diseased liver and can help stop bleeding and fluid backup. Of course, there's risks included with this procedure as well, which includes hepatic encephalopathy, which occurs in 30 to 50% of patients, shunt thrombosis, shunt stenosis, or infection. In my opinion, the paracentesis is less invasive and will give us the answers we need to treat your condition. Next, we have a step-by-step of the procedure. So the patient would be placed in the lateral decubitus position. Ultrasound is used to identify the area where the most fluid is located. The area is then prepped with an antiseptic solution and draped in a sterile fashion. The local anesthesia is injected to the skin and the soft tissue down to the peritoneum at the planned site of needle insertion. The needle or catheter is attached to a syringe and is then inserted perpendicular to the skin or using a Z-track method, which is the most common method. If using a catheter kit, it may be helpful to make a small nick in the skin using an 11-blade scalpel to be able to advance the catheter through the skin and soft tissue smoothly. While applying negative pressure to the syringe or catheter insertion until a loss of resistance is felt and a steady flow of acidic fluid is obtained. Advance the catheter over the needle into the peritoneal cavity. After you collect sufficient fluid in the syringe for analysis, either remove the traditional needle if you're just performing it for a diagnostic tap, or connect the collecting tube to it or the catheter stopcock to drain a larger volume of fluid into a vacuum container, plastic canister, or a drainage bag. After you have drained the desired amount of fluid, remove the catheter and hold pressure to stop any bleeding from the insertion site. Describe the evaluation and management based on this particular patient. So the results of the fluid drained shows that the patient has a spontaneous bacterial peritonitis with portal hypertension, as evidenced by the SAAG of 1.2. SPB is an acute infection of the abnormal accumulation of fluid in the abdomen without an identifiable source of infection. Therapy is done with an intravenous third-generation cephalosporin, which should be started in all patients with a suspected SBP with a PMN count of greater than 250. Our patient had 550. Once the results come back with a specific organism found, the antibiotics can be adjusted. A follow-up paracentesis should be done to evaluate that the numbers are going down and the therapy is being effective. This is important as lack of improvement after 48 hours of therapy may indicate an underlying perforation or abscess formation, such as secondary bacterial peritonitis, which may require surgery. What is the health promotion disease prevention that would be implemented to prevent this outcome? This patient would benefit from sodium restricted diet in order to reduce the retention of sodium. So a 2-gram daily sodium diet. Diuretic therapy with furosemide promotes urinary sodium loss and also reduces the risk of hyperkalemia from the spironolactone, which should also be taken. The actions of aldosterone to promote sodium retention in cirrhotic patients can be antagonized by spironolactone. And then paracentesis whenever needed, to help the symptoms of the bloating and the accumulation of fluid. The most that can be removed at one time in one sitting is 5 liters, so nothing more than that. My 2 open-ended questions are: what are alternative treatments for ascites besides paracentesis? And how do you determine portal hypertension and how do you treat it? Thank you so much, and I hope you enjoyed my video.